Thank you. Hello, everybody. And Leana, hello to you out there. Welcome.
Hi, great to join you all.
Thanks. So it is such a privilege to be sitting with all three of you actually in person when I, like hundreds of thousands of other people, am much more used to seeing you on Twitter or other social media sharing incredibly rational and helpful information in the midst of all this. I wanted to start with some very big numbers. So Leana, you have close to 180,000 Twitter followers. Let's see, Scott, you have 512,000 at latest count. And I should just mention again, actually, Scott, your latest book is called Uncontrolled Spread. Leana, yours is called, tell us the title.
It's called Lifelines.
Thank you. That's the short version. Okay, and also Andy, the winner, with 697,000 followers, plus another 179,000 in two accounts. It's a little confusing, right? But basically, and a new book out too with the title Preventable. So I would like to start by just thanking all of you for your courage, actually, in that you are fighting on a very special and kind of bloody, nasty front, which is the information front in this pandemic. And I just wanted to ask you first and foremost, like, how do you stand it? How do you stand the slings and the arrows and the nastiness and the abuse that you have to take as you try to spread reliable, solid information? Leana, can we start with you?
Sure, first I want to say it's a pleasure to join you all. I'm sorry that I'm not there in person and I'm this disembodied screen, but great to join you, Carey, and great to see Scott and Andy as well. I mean, I think for me, I'm a clinician, I see patients, and every day when I'm in clinic, I think back to what it is that we're here for and what is our North Star, which is helping the patient in front of me. And so I think for all of us, really there's something that drives us, and what drives us, I think for all of us and everybody in the audience, is the desire to provide that accurate information, because ultimately disinformation takes away people's freedom to make the best choice for themselves and for their families.
Thank you. Scott.
Yeah, look, I felt a real need over the past year to try to get out good information about what was going on early on, trying to draw attention to things that I didn't think were being done, particularly around the early scale-up of the diagnostic testing, which I felt we needed to get the private industry engaged much more quickly, and that really set us back at the outset. As far as the criticism on social media, I don't ignore it. I do look at comments, particularly after I engage the media. I go on TV because I want to see how people are reacting to what I'm saying, making sure that what I'm saying is translating in a way that I intended to. But there's a lot of vitriol out there, and that I too do try to ignore. I try to subordinate it. But it's been a tough year. There's been a lot of attacks on all of us.
Yeah, Andy.
I think first of all, particularly Leana and Scott, super important, because none of us are as good as the misinformation purveyors are, because they play dirty. They're willing to lie. They're willing to play those algorithms and spread untruths, whether it's about vaccination or anything else. And so, for the two of you, for myself, trying to give people the straight story is a disadvantage, because you're playing by the rules. But it's really important that people find places they can go for reliable information, wherever that is. And look, I think I consider myself fair game because I was a public official, and therefore I think goes with the territory. But the thing is, you never know is, like, are these people even real? Like, are they Russian bots? Are they fake? I don't even know, like, whether you're getting attacked by real people. So it's hard to know whether to take them seriously. If someone has a valid criticism, I will take it to heart. But if some person who isn't going to provide their real name, misspells some nonsense about you, it's hard to, life's too short to let that stay in your head for too long.
Last week I was attacked on the same day by Chinese state media and the Russia Times. That felt pretty real.
Well done.
Wow. And Leana, I believe it's public that someone was even recently indicted for threatening you. Is that right?
Yeah, so I can't speak about this as it's an ongoing investigation, but I do want to say, I mean, I've talked to public health officials from across the country, local and state health department leaders, but also contact tracers, people working in school health. I mean, individuals who are on the front line staffing senior centers or working in clinics who have been attacked, harassed, assaulted for doing their job. And really, this should not be acceptable. I mean, I think all of us were trying to provide accurate information. We're helping people to navigate some really challenging circumstances. And you know, it's a really confusing time. And I understand that people are really angry about what's happening in their lives. But I hope that we will not be directing the anger at one another, and especially at people who are trying to provide information, do outreach, get vaccinations, increase testing, and do the work to try to end this pandemic.
Just to pick up on that, what Leana said, I think there's clearly over-the-line behavior. People who don't know how to engage in normal discourse, don't know where to direct their anger. There's a lot of anger right now over things that have evolved. But I think that there's a broader sentiment that is, I don't want to say mainstream, but it's much broader and it's more ingrained in that people are questioning what the role of public health officials should be in a public health crisis. And everything that we envision in terms of how we prepare better for the next pandemic, and what I write about in the book, is going to be about empowering public health agencies, giving them new tools, new authorities. And so if we're going to be better prepared the next time, we're actually going to need a CDC that is more empowered, not less. And there's a large swath of the public that are skeptical of the advice they got, felt the guidance wasn't well informed, was conflicting, that public health officials had too much authority. And I think that there is a presumption that this is a right-left debate, and most of this is on the political right. And there's no question more of it's on the political right, but it's not all on the political right. And I think that as public health people, we need to recognize the skepticism and recognize that we're going to have to make the case for why what we did was right, and why it's important to have public health officials leading in a public health crisis.
Yeah, well, actually, just to vent as a health and science reporter, I found it incredibly frustrating, especially at the beginning of the pandemic, to feel like I wasn't getting enough public interaction and public information from the state public health officials, actually. And some of it was that we didn't have enough information, but there was a huge public demand for information. And normally my job would be just to kind of parrot what the officials said, but we didn't have the officials saying enough. And so it's interesting to me that the three of you and others like you kind of stepped up into a role of sort of a public health, public intellectual who would share directly with the public your best understanding of what was going on. And so it sounds like you're saying we need to make this official. All of the people who've been doing that, we need to actually have these places, these official spots where people will be communicating in public more.
Yeah, I think it's broader than that. I think as public health leaders, I think at some point we're going to need to make the case about why the public health advice was sound in the setting of what we knew and what we had to do. We're going to have to defend our position, because in order to get the right authorities in place and the right resources and build the right institutions, people are going to have to trust in empowered public health institutions. And they didn't 6 feet, 3 feet, 10 feet, 15 minutes of exposure, 15 minutes of a cumulative exposure. It just felt like things were shifting constantly, and the public wasn't following this closely enough to understand the nuance and understand why things were evolving. They just saw the evolution and it felt unreliable. And that's what I worry about.
Yeah. Leana, the latest informational challenge that has arisen just this week was the death of General Powell, and the concern that people might take away the wrong message. How have you taken that on?
Well, I'll address this, but I wanted to follow up on something that Scott, on two things that Scott was just saying. One is, I think looking back, I wish that and I think we as a public health community had done an even better job of messaging that change is to be expected in a public health crisis.
Yeah.
I think that, I mean, we all knew that. Of course we knew that. I mean, this is a new pandemic, a new virus. Of course, we're going to be adapting. And actually, we can use a clinical example here. If you're treating a patient who has cancer and a new chemotherapy drug comes out, of course, your patient would be expecting that you tell them about it and then you make a decision together based on new evidence. But I think somehow that's gotten lost, and as a result, it looked like we were flip-flopping, whereas flip-flopping is what happens when the science doesn't change, you just change your mind, as opposed to the science changes and your guidance evolves along with it. So I hope that going forward, we can do a better job of messaging that change is the bedrock of a solid public health response. But I like Scott, I'm very worried about the erosion of trust in public health authorities writ large. We've now seen, I think the latest statistic from the New York Times is that there have been over 100 laws that have been passed in legislatures across the country that limit local and state health authority. And so I really worry not just about this pandemic, but what happens next time? What happens if a local health department can no longer do quarantine and there's a patient with multi-drug resistant tuberculosis? What happens if there's a new virus that comes out, a resurgence of measles, and now masks are not something that the local health department is able to provide? And so I really worry about that. But Carey, to your question about this week, I think this was another example of facing misinformation head on, because there were anti-vaccine activists who seized upon the tragedy of General Powell's death to say, hey, that's evidence that there's no point in getting vaccines, as opposed to saying that this is the reason why we all need to be vaccinated. You know, we all need to be vaccinated to protect the most vulnerable among us. The problem is not a defective vaccine. The problem is that our community spread is too high. And if anything, this should be a call to action for all of us to do our part to increase vaccination.
Yes. Andy, do you want to add?
Yeah, sure. I mean, look, first of all, it's a very public loss, but it's a very public loss that occurred on the same day as another 1,500 very private losses. And so to some extent, the big thing that people take away, beside from the vaccination question, is that this is real and this really affects people and we're at risk. And, you know, a vaccine it can only be as good as your immune system is and your ability to take it. And if you've got a troubled immune system, like General Powell did with multiple myeloma, sadly, you need community vaccination around you. And that's what people don't understand yet. They don't understand that there is this interdependence. But I do want to touch on the kind of point around expertise that we've been sort of dancing around. And you know, Scott makes some good points in his book about things that have been done wrong, and Leana makes some good points about things we could have communicated better. But I think it's important to recognize that the distrust of expertise preceded the pandemic.
Absolutely.
And was something that has been building for decades. You know, we now need to understand and face facts. Everybody in this room needs to face the fact that at least 25 to 30% of the public does not trust a thing we do. They don't trust public health. They certainly don't trust for-profit companies. They don't trust pharmaceutical companies. They don't trust government. And we are not talking to them. We are talking past them. And this pandemic has only worsened that perception that we are arrogant. We don't admit we're wrong. We talk above people, and then we talk down to them. And in a lot of things in life, you can do fine with 75%. You can win an election. You can have a veto-proof Congress. You can do a lot of things. Unfortunately, this pandemic is less forgiving. And having 75% of people on board just isn't enough. And so the fractures in our country that have preceded the 2016 election, preceded the pandemic, are things that are very important that we understand and face. They are not the result of superficial things that happened in the last couple of years.
Right.
They're the result, unfortunately, of some very deeper things that have left people feeling dispossessed.
Right. So I'd like to move right to solutions. Each of you are big picture thinkers that have written books now, taking a step back at the whole picture. What would you name as 2 or 3 of the most important things to do before the next pandemic so that the shortcomings in our response are not repeated. Leana, could we start with you, if that's okay?
Sure, although I think I might go in a different direction than Andy and Scott, and maybe in a different direction than what people are expecting for me to say. You know, prior to the pandemic, I had a concern, which was that public health isn't known. People don't see it because by definition, public health is about prevention. And so my concern was about elevating the role of public health so that it doesn't become the first thing on the chopping block when it comes to budget time. I have a different concern now, which is that public health has been so politicized, so polarized, and it is now being put into the middle of ideological culture wars. I'm not taking a stand on this, but I'm just saying it is literally an issue, and I'm very worried about public health being equated with COVID-19, or public health being equated solely with infection control, when that's one part of what public health does, but not all of it. And so actually, if there's one thing that I would do, to, yes, prepare for the next pandemic, but in general, to help to bolster trust in public health more broadly, it's to not talk about COVID-19 as the only thing that public health is about. And in fact, it's to talk about those elements of what public health does every day that aren't polarizing, that aren't politicized. For example, and this will differ in communities around the country. For example, in Baltimore, where I am, our program Be More for Healthy Babies, that's reduced infant mortality in our city by 38% in a 7-year period through home visiting. I would talk about the programs to prevent lead poisoning, the programs to prevent falls in seniors, to provide telemedicine in schools, and provide glasses and asthma treatment for our kids. Things that I think the vast majority of people can agree to are important. I would focus on telling those stories, scaling up those programs, bolstering our public health infrastructure when it comes to many of these other issues that were crises prior to the pandemic but have not gone away. For example, the opioid epidemic was an epidemic before COVID. It's only gotten worse. Mental health care, focusing on mental health, because that's something that we can generally agree to is very important. I'd really emphasize these things, and I hope that can help us take a step back and not have public health in general be under these harsh lights and misunderstood, as unfortunately it's been.
Thank you, Leana. Scott.
Well, I think there has been far too little focus on therapeutics. Operation Warp Speed was Operation Vaccine, and this pandemic taught us what we already knew, which was that in a pandemic, the first line of defense is likely to be a therapeutic. And in fact, in this pandemic, the first line of defense was a therapeutic. We didn't adequately resource the manufacturing of it. We didn't adequately put in place the infrastructure to distribute it, the monoclonal antibodies. And we had almost a singular focus on trying to get to a vaccine, which is essential for ending a pandemic, but a therapeutic is going to be a bridge through a pandemic. And there's the potential to create therapeutics that could have broad effectiveness against whole categories of viruses. The Merck drug looks like it's effective against multiple RNA viruses, respiratory viruses, including influenza and coronavirus. That's why DARPA funded that drug in the first place. Regeneron had been trying to fashion a pan-coronavirus antibody against MERS that was never funded by the government. So we have the potential to create therapeutics that could be a hedge against a future pandemic. They're not going to end a pandemic, but they could be a bridge at saving lives while we get to a vaccine. And we gave far too little effort to developing therapeutics. I mean, the government really only placed bets on 3 small molecules. And for the Merck drug, we're only going to have 1.7 million doses, an option probably on a little bit more. A year and a half ago, we could have been placing a far bigger bet on that. The other thing I would just say
Scott,
is,
just to interrupt for 1 sec, why didn't we?
I think that the people who were making decisions early on in Operation Warp Speed had a singular focus on vaccines. The orientation always was to try to get to a vaccine, and there was much less effort put into trying to scale up the discovery development of therapeutics.
I will say to Merck's credit, I'll go back to it in a second, they're committed to distributing this drug equally around the globe and not advantaging wealthy countries. And that is a bit of Merck's heritage, and good on them for that. but we're not going to get over-allocated. Now, Scott's right. We could have done enough to protect ourselves, but each country looking out for themselves is just another version of each of us looking out for ourselves.
Yeah, and just to get, you talked about Colin Powell. There are functionally immune and competent people who are not going to mount an effective response to a vaccine. People who are on immunosuppressants, people who are on active chemotherapy. We should be prophylaxing them on a monthly basis with Regeneron or Lilly or Vir Biotechnologies antibody. There's really no argument not to do it. The EUA is in. I suspect it will get authorized. We could be potentially saving a lot of frail lives, but we don't have the infrastructure and we don't have the supply right now to do that. I think at this point we probably do, but we have not. So there's a missed opportunity there.
And
as a
Andy
bridge.
and Leana, do you agree that we should be doing that? That we should be providing monoclonal antibodies to immunocompromised people regularly on a prophylactic basis?
It's a question to Leana, I guess.
Leana?
Well,
I don't know. I mean, I definitely think that monoclonal antibodies are far underutilized. I would also very much agree with Scott on another point, which is the importance of testing. I think we really have not focused the same amount of attention on testing and on therapeutics as we have on vaccines.
Yeah.
so I worked with Regeneron when I was in the White House on a plan to do that, to kind of ring around communities that have been vaccinated. And I think something like that, particularly if you could administer it subcutaneously or particularly
Which
the
you'll
oral,
be able to do soon. And I'm not saying in
Yeah.
perpetuity, but through the Delta wave, going into nursing homes and giving everyone a shot of a monoclonal antibody to get them through that wave. It's 1 month. It might last longer than that based on the data.
Yeah.
The other point, I'll just wrap it up quickly on what we should be doing.
Solutions.
Is I think we need to get our national security tools much more engaged in the public health mission, which has always been taboo. The public health community didn't want our spy agencies anywhere near this mission globally. We cannot rely on multilateral commitments and capacity building alone to get us the information we need in countries that could be emerging hotspots on pathogens that could threaten the globe. We've seen time and time again, no matter how binding the commitments are that are made at the World Health Assembly, countries don't adhere to them. And if anything, COVID conditioned the world to expect trade and travel restrictions when they raise their hand and say we're host to a new pathogen. What's the first thing that happened when the British said they had B117? The French closed the channel. We all remember the lines outside the channel. So what country is going to raise their hand willingly if they know it's going to invite trade and travel restrictions? We have to be getting our foreign intelligence agencies engaged in monitoring. There's ways to do it. There was information available by mid-December in Wuhan that could have been obtained that would have given us a month-long head start. And in the hands of a competent political response, that a month-long head start would have been measurable.
What do you think, Andy?
I think they're both right. I mean, it's not surprising we all talk to one another, and I think there's violent agreement. And you probably need an equivalent of an NSC structure for bio threats. Since they covered the two areas they covered, I'll just cover a third area, which I know both of them agree with as well, or they can disagree if they don't, which is equity. The things that are just become so abundantly clear around what your life is like in this country today if you work by the hour versus if you have a salaried job and can work in an office have never been more stark, let alone rural communities, people of color, older people, sicker people, people with chronic conditions. So that didn't jump out at us. And then, of course, globally, the same lesson. We're going to get whacked again. It's going to come from another country who's not had enough vaccination. So we need to be much more focused on that. So what are the top 3 things we could do? I would start with pass the damn child tax credit and make it permanent. Get people out of living in poverty. There you go. Get kids out of living in poverty. The kids who during the pandemic couldn't learn because they didn't have internet at home and couldn't eat because they depended on school lunches. Forget waiting for the next pandemic. They're dealing with the pandemic tomorrow. So I think if we don't solve those problems, I have very little faith that we're going to solve the other problems, because as soon as you get past the level of being able to contain the virus, and if, God willing, something happens again, we can contain it, our technology works for us, all the things that Scott wrote about in his book, all the things that Leana's done her entire life in public health, great, we win. But if we don't, if we are overpowered again, then guess who we're dependent on? We're not dependent on the public health agencies. We're back to being dependent on one another. And that's where I think we have a lot to learn, because when we become dependent on one another, that's when the fabric of society really is broken for us. So let's fix those things that we can fix now and get people access to universal health care coverage, get people access to childhood tax credit, get people the ability when they're sick not to have to go to work, right? Think about what that would have done for the pandemic if people would have had paid family sick leave.
Yeah. Leana, do you want to add to that?
Only that I very much agree with Andy about the issue of equity. That if it's anything the pandemic has taught us, it's that COVID didn't create disparities, but it has unveiled rampant disparities that have long been there. But we've also seen that unless we are intentional about addressing these disparities, they only worsen. I mean, we saw that initially with the vaccine rollout. Now we're going to see this again with distribution of boosters. We're seeing this with access to testing and therapeutics, that individuals who are privileged are going to be able to find access to all of these things, but the individuals who are particularly vulnerable are going to be left behind. And I hope that, I mean, I know there are so many people in the audience who work in health and tech and innovation, and I just would want us to keep in mind that as we're coming up with new products and new innovations that are so exciting, I hope that we're also focusing our attention on what we can do to bridge that disparity, that gap, because equity isn't about somehow taking years from one group of people, taking years of life from one group of people and adding it to another. Focusing on equity and focusing on those who are the most vulnerable, in the end means that it benefits us all and improves health for all.
Right. So we only have time for maybe one or two more questions. I would just like to ask you, the question was kind of like, what's most driving you crazy? But I think maybe a more positive way to ask it would be, on your to-do list of all the things that could be done right now to improve our status in the pandemic, what would be the number one thing at the very top of your list? Leana, if you would, let's start with you. Sorry.
I'll do this very quickly. Testing. We need to have widespread testing the way that we do, that other countries have access to. The United Kingdom, for example, families can get free rapid testing twice a week if they wish. That is something that's totally within our capabilities. The Biden administration has done so much right during this pandemic. I wish that they would put the same amount of effort into testing as they did in vaccines, because we're going to be living, for better or for worse, we're going to be living with COVID-19 for the foreseeable future.
Yeah, if you were here, you would have been tested on your way in probably. They've been doing thousands of tests, which is a really interesting experiment that seems to be working. Scott.
I agree with Leana's point. I think the other thing I'd add is that we need to decide what our goal is in terms of what we think we need to achieve with adult vaccination. 78% of adults over the age of 18 have now had one shot of the COVID vaccine, which is an exceptional number. If this was B117, we'd be done. It's only because of the Delta variant that we have to get to higher rates. What is the goal? The goal might be 85%. Tony Fauci has talked about that. What are the different policy options that could get us there? What increment do we think each policy option will have towards getting us there, and what's the price we will pay? Right now, the policy seems to be more, and the policy options seem to be whatever it takes to get more. And some of that is creating divisions that I worry is going to have long-term implications, not just in COVID-19, but it's going to create a culture of people who think that they have to be reflexively against vaccines because they're not going to differentiate the idea of a COVID-19 vaccine mandate and the idea of being against a vaccine that the government's encouraging you to get. And we are at risk of seeing vaccination rates go down from MMR and childhood immunization and flu. You're already seeing politicians run against the idea of mandates. They're going to run against the idea of childhood mandates? I mean, we're going to be rolled back 50 years on this? So I think we need to tread very carefully and decide what price we're willing to pay to get from 78% to 85%. And if we only end up at 84%, is that okay?
Andy.
Vaccinate 70% of the globe by April of 2022. And that needs to be a mission we all commit to. It's the surest way to prevent variants. It's the surest way to prevent more loss of life. And we're producing enough vaccines to do it. We're producing 1 billion vaccines a month. We will have vaccinated the lion's share of the globe other than basically continental Africa, some parts of Southeast Asia, and rural parts of South America and other parts of few other parts of the world. To do that, our problem is a last mile problem.
Yeah.
It's not a vaccine production problem. It's what I spent 4 months on inside the White House, literally getting vaccines in arms. We should send all the troops that used to be in Afghanistan, and we should send them to Africa, and we should start putting needles in people's arms. The UN should do the same. We have the money, we have the vaccines, we need the will, and we need the operational know-how. It is mission critical, and we need to treat it that way.
Yeah, this is a distribution issue. There's going to be a lot of supply coming online.
Yeah.
And the more we talk about supply being the issue, the less people are focused on the challenge where we're going to need massive investment, which is on the ground distribution and infrastructure that has a very long lead time, and we're not making the investments we need to be.
And then we need an oral or a nasal vaccine,
Yeah.
or we're not really going to get the rest beyond the 70%.
So do you think that vision that you described will come to fruition?
April?
Yeah.
Right now, I think we're tracking about 4 months behind it, but we're tracking 4 months ahead of where we were a few months ago. So with commitment, we can do it. It's going to require the G7, probably the G20, to really make it happen.
Great. Thank you. Well, I hope you'll all join me in thanking our panelists, not just for today, but for all the tweeting you do all the time. Thank you.
Thanks, Leana.